At this stage, it's essential that you understand some respiratory physiology, and the material that's covered in these two tutorials on carbon dioxide and ventilation are essential knowledge for all practicing anesthesiologists, intensive care specialists, or really anybody who ever touches a mechanical ventilator. In this particular tutorial, we're going to look at alveolar gas, we're going to look at ventilation, and then we're going to address the problem of dead space ventilation and why it's important. And following that, we'll just briefly touch upon auto-PEEP. Tutorial 7. Understanding ventilation. Previously, we looked at volume control ventilation, and we started looking at the primary principles of volume control, and then we looked at volume assist control ventilation and different types of problems that you might encounter if you use this mode of ventilation. There are significant advantages to volume control, but there are problems with this mode. We then moved on to look at intermittent mandatory ventilation and how it evolved from anesthesia machines back in the 1950s and 60s. This was updated in the 1980s to look a lot like assist control and became synchronized intermittent mandatory ventilation with a novel mode known as pressure support. I think at this stage that it's worthwhile looking at the underlying physiology behind ventilation as a concept. This is the movement of air in and out of the lungs. This is really mandatory applied physiology for anybody who works in the ICU, whoever engages with patients who have respiratory failure. I'm going to start with oxygen and CO2 and alveolar gas, and then we're going to look at alveolar ventilation and hypercarbia and how these interact. And finally, we're going to delve deep into anatomical and physiologic dead space. Let's start with a scenario. You're in the ICU and you encounter a patient whose name is Freida. And Freida is intubated and attached to a ventilator, and she's on volume assist control. The settings are as follows. She has a tidal volume of 370 mils. She's on 15 breaths per minute. She has a PEEP of 5 and an inspired oxygen tension of 28% or 0.28. She's not triggering the ventilator. Her blood gas reveals a pH of 7.38, CO2 of 40 millimeters of mercury, that's 5.1 kilopascals, PO2 of 100 or 13 kilopascals with a normal bicarbonate. Here's the thing. Why isn't Freida breathing? And this brings us to the question of, well, why do we breathe? The reason why we breathe is to facilitate respiration, and that is the generation of chemical energy from nutrients that require oxygen as part of the process and results in the production of carbon dioxide as the major waste product. The base requirement to keep the system running is approximately 250 mils of oxygen per minute, and that results in the production of about 200 mils of carbon dioxide that needs to be eliminated. Oxygen is inhaled from the air, of which it constitutes 21%. This is Dalton's law. 21% of atmospheric pressure is the inspired partial pressure of oxygen. And it is always 20% regardless of whether you're at sea level or up the top of, for example, Mount Everest. It's always 21%. Carbon dioxide is expelled by the lungs via the same blood-gas interface. When we use the term respiratory failure, we are really describing one of three processes that can go on simultaneously. The first is failure to oxygenate, characterized by reduced partial pressure of oxygen in the blood. The second is failure to ventilate, characterized by raised partial pressure of carbon dioxide in the blood. The third is failure to protect the airway, and that's characterized by airway obstruction, and that may be caused, for example, by coma or infection or a problem anywhere along the respiratory system. Let's go back to Freida. Freida either can't breathe or she won't breathe, so she is failing to ventilate. Ventilation refers to the process of moving air in and out of the lungs. Inward flow, triggered by diaphragmatic movement, delivers and replenishes oxygen to the alveoli. So it fills up the alveoli with new air. And then, of course, When we exhale, the stale air gets pushed out of the alveoli into the airways and out of the mouth, and that's how we get rid of carbon dioxide. We also expel some oxygen, obviously, as we're exhaling. Essentially, the whole process is about getting oxygen into the lungs and carbon dioxide out. However, it's really important to understand that the major driver of breathing is carbon dioxide itself, and in general, the rate and depth of ventilation is targeted at keeping the PA, that's the partial pressure of carbon dioxide in arterial blood, within the homeostatic range, in and around 40 millimeters of mercury. Let's have a quick look at airway anatomy. Gas enters the lungs and travels via the larynx into the trachea, and that splits to bronchi, bronchioles, terminal bronchioles, all the way down to alveolar sacs and alveoli. 23 generations in total. At each level, the airways are vulnerable to being blocked off, either due to material in the lumen, such as inhaled foreign bodies, or blood, or sputum, or due to external compression. The total volume of these conducting airways is approximately 150 mils. This varies depending on height, and no gas exchange occurs within them. Thus, conducting airways are dead space for gas exchange. The gas is in the lungs but not currently available to blood-gas interfacing. Nevertheless, as gas exchange occurs continuously, oxygen that is contained within the conducting airways continues to diffuse into the alveoli along the concentration gradient as oxygen is taken up by the blood. As such, dead space is a reservoir for oxygen and a transit lounge for carbon dioxide. This is a cartoon of the respiratory zone characterized by the bronchioles and the pulmonary arteries. Before I go further, I just point out that the pulmonary artery here is represented by a blue structure, and that's important to understand. Remember, pulmonary arterial blood is deoxygenated. It is mixed venous blood. It's what comes into the right ventricle. Pulmonary venous blood is oxygenated and goes into the right atrium. So pulmonary venous blood looks like systemic arterial blood, and pulmonary arterial blood looks like systemic venous blood. And that's important when I move on to looking at ventilation perfusion a little bit later on, just to keep that in mind. Now, there are then clusters of alveoli that are surrounded on one side by pulmonary capillaries. Blood exiting the alveoli go to the right atrium. Let's zoom in on just one alveolus. And you can see here we have an alveolus that has a pulmonary capillary from the arterial side on the left, and the pulmonary vein, which is on the venous, is on the right side. And the colors are not what you might expect. So the blue side is the pulmonary arterial blood, and the right side, the red side, is the pulmonary venous blood. And in the pulmonary arterial blood, the CO2 tension is about 44 millimeters of mercury, or 5 kilopascals. There is a gradient between the partial pressure of CO2 in that arterial capillary versus the alveolus, where there's a slightly lower CO2 at rest. And so what happens there is that the CO2 diffuses in to the alveolus until the partial pressures are equalized, and the CO2 is then transmitted along through the dead space into the atmosphere, and we can measure that. That's the end tidal CO2. Simultaneously, obviously, oxygen is diffusing inwards and from the alveoli into the blood. Eventually, once equalization has taken place, the partial pressure of carbon dioxide in the pulmonary venous blood, which is the same as the systemic arterial blood, is about 40 millimeters of mercury. The alveolar CO2 settles down at around the same level, 40 millimeters of mercury, or 5.1 kilopascals. Let's look at failure to ventilate. Failure to ventilate should be looked like at this way. The main purpose of ventilation, that is taking a breath in and expelling a breath out, is to refresh oxygen in the alveoli and the dead space and expel carbon dioxide. This process requires adequate alveolar gas turnover to remove a minimum of 200 mL per minute, and it's known as alveolar ventilation. If alveolar ventilation is inadequate, carbon dioxide builds up in the body, the blood becomes more acidic, blood pressure falls, and the patient becomes somnolent. This may ultimately result in cardiac or respiratory arrest. Why do patients fail to ventilate? The first reason is failure to generate adequate minute ventilation, and the causes of this are either anatomical or neuromuscular. The second cause is failure to clear carbon dioxide from the airways, usually despite adequate minute ventilation. And when I mean say minute ventilation, I mean this is the tidal volume times the respiratory rate. This is measured on all mechanical ventilators. We can't directly measure alveolar ventilation. We can only measure minute ventilation and hope that the two of them match somewhat. The problem of failure to clear carbon dioxide in this setting is caused by ventilation-perfusion mismatch, dead space, and auto-PEEP. Let's start with failure to generate adequate minute ventilation. I usually, when I look at these problems, I start with the brain and work my way down. And of course, the control of blood carbon dioxide levels is determined by chemoreceptors in the medulla of the brain that respond to the local acidity of the CSF. And so when CO2 levels go up, CSF becomes more acidic and the patient takes deeper and faster breaths. That's what happens when, for example, you go for a run. So higher PaCO2 increases alveolar ventilation. Why would that be interfered with? Well, it can be interfered in major pathology by brain injuries, for example, ischemic brain injuries such as stroke, hemorrhagic stroke, blood or traumatic brain injury or interparenchymal hemorrhage. All of these things can cause a brain injury that will affect respiration, but more commonly it's caused by poisoning, and that is drugs that interfere with the responsiveness of the medulla to carbon dioxide. In our practice, these drugs are anesthetic agents like propofol, thiobarbiturates, or benzodiazepines such as diazepam or midazolam, but the big player in this are opioids. All opioids depress respiration by definition. And the shorter acting and the more potent the opioid is, the more effective it is at suppressing respiration. And it does this by making the chemoreceptors in the medulla less sensitive to changes in the local acidity. Roughly 110 or 120,000 Americans die each year from opioid overdoses because the dose that they've been given is sufficient to suppress respiration. Now, once the medulla triggers respiration, the information needs to be passed down through spinal nerves, and the key nerves here are C3, 4, and 5. They're the ones that keep the diaphragm alive. And also the phrenic nerve, which runs down the neck. So if a patient has a major spinal injury, for example, a subluxation or a fracture in the cervical spine, this can affect the spinal nerves and essentially paralyze the diaphragm. There are other diseases that may affect these nerves, such as Guillain-Barré syndrome or other demyelinating disorders, and indeed a phrenic nerve injury during surgery, or even partial paralysis of the phrenic nerve during, for example, an interscalene block that will reverse over time. Then we move down into the thoracic pump. The thoracic pump is the apparatus that allows the chest wall to rise up and lift itself off the lungs so that the lungs can expand. And it involves the ribs and the chest cavity and the muscles, but principally the diaphragm and the intercostal muscles. So that's your thoracic pump, the diaphragm and the intercostal muscles. And anything that impedes neuromuscular transmission can impact the ability of the thoracic pump to work. So in anesthesia, or indeed in the ICU, the administration of neuromuscular blocking agents such as rocuronium, pancuronium, atracurium, cisatracurium, vecuronium, all of these things will essentially paralyze respiration, switch off the pump. It can also happen in myasthenia gravis, where you have autoantibodies that bind to the neuromuscular end plate. And then, of course, we see this quite a lot in chronic critical illness, where patients have devastating myopathy and they just can't breathe because all those muscles are very weak. And finally, sometimes the patients just stop themselves from breathing by withholding breaths because they feel pain when they inspire. And we see this quite a lot after upper abdominal surgery. The other cause of failing to ventilate is anatomical. And if you follow the gross anatomy of the respiratory apparatus, there are medley places where things can go wrong. So let's start with the mouth and work our way down. First of all, we have our upper airway. Remember, gas passes up through the mouth or the nasal passages and then into the pharynx and down to the larynx. So anything that gets in the way of this is problematic. So a hugely swollen tone due to, for example, a hematoma or an inflamed pharynx or submandibular area that compresses the airway may prevent gas from flowing. So we're looking at things like trauma, masses, even tumors may cause this in the upper airway. Then we move down to the larynx and the trachea and the bronchi. The larynx itself may be damaged and you could have laryngeal edema or laryngeal obstruction with a foreign body. This is what we call choking. Perioperatively, this may occur, for example, if a throat pack has been left in after the patient has been extubated. The vocal cords may be paralyzed, for example, during thyroid surgery. The trachea itself may be compressed by an enlarging thyroid gland, particularly a thyroid tumor. The bronchi and the bronchioles may become obstructed either due to bronchospasm or an obstruction in the lumen, in the wall, or outside the wall. And then subsequently, if we go down through the chest, we have the chest wall itself that needs to move to get gas in and out. And anything that impedes the ability of the chest wall to spring outwards, to move outwards, is problematic. And what those problems are things like fractured ribs or a flailed chest, or material within the pleural cavity that prevents that stretch. Pneumothorax, pleural effusions, hemothorax, all of these things will cause a sort of a chest compartment syndrome, preventing those lungs from expanding. And one thing that you really should be aware of is intra-abdominal distension. So a big globular abdomen that may contain a lot of fluid or distended bowel or packs will compress up the diaphragm and prevent diaphragmatic excursions. And this is known as intra-abdominal hypertension. An extreme version of this, of course, is abdominal compartment syndrome. Why would one fail to clear carbon dioxide despite adequate minute ventilation? So the patient may have plenty of gas going in, but for some reason they're not clearing CO2. And it's important at this stage to visit the alveolar gas equation. This is the most important equation in respiratory physiology, and it essentially determines the content of alveolar gas. If we are at sea level and the atmospheric pressure is 760 millimeters of mercury or 100 kilopascals, and it contains 21% oxygen and 79% nitrogen, we can apply Dalton's law and multiply the partial pressure of oxygen to the atmospheric pressure. So it's 0.21 times 760, and that gives us the inspired oxygen tension of the air. Now, once the air has been inhaled into the mouth, of course, it encounters a second gas in there in the airway, and that's water vapor. And water vapor has its own pressure, and that's 47 millimeters of mercury. So as the gas travels down into the lungs, you have nitrogen, oxygen, and water vapor. And so by the time the gas gets to the alveoli, it has these three components and then has a fourth component, and that's carbon dioxide. About 5% of alveolar gas contains carbon dioxide. So that has to be accounted for as well. And so the way to calculate out the partial pressure of oxygen in the alveoli, it's 713, that's 760 minus the water vapor pressure multiplied by the inspired oxygen tension minus the partial pressure of carbon dioxide. And there is a factor there known as the respiratory quotient that looks at the relative consumption of oxygen versus generation of CO2, and that's about 80% or 0.84. So that's where that number 250 mils of oxygen or 200 mils of carbon dioxide come from. And so that's in general, the more carbohydrates we eat, the higher the respiratory quotient, the less the lower, because fat and protein generate less carbon dioxide. There is an alternative version of the alveolar gas equation, which is the PiO2, that's 760 minus the partial pressure of water vapor, minus the PaCO2 multiplied by the PiO2 minus the end-tidal oxygen divided by the end-tidal CO2. So there's a couple of versions of this, and there's a really extended version of the alveolar gas equation, and it can get very, very, very complicated, but you're better off just staying with this very basic one that uses the standard respiratory quotient. And I've been using this for years, and it's very, very helpful. And it used to be the way that we conventionally quantified hypoxemia, looking at the alveolar to arterial gas differential. And we'll talk about that when we talk about hypoxemia. But let's just do a quick calculation. What is the alveolar oxygen tension if the inspired oxygen tension is 40%, the PaCO2 is 60 millimeters of mercury or 8 kilopascals, and we are at sea level? A higher than usual FiO2 and a higher than usual PaCO2. Let's work the problem. So the P alveolar, big A, O2, is the PiO2, that's the atmospheric pressure minus water vapor pressure multiplied by the inspired oxygen tension at 0.4 in this situation, minus the PaCO2 divided by the respiratory quotient that we're taking at 0.8 because we don't know any better. So that works out at 713 multiplied by 0.4 minus 60 divided by 0.8, or 285 minus 70. That works out at 15 millimeters of mercury or 28 kilopascals. Just another way of looking at this, and this is for a normal patient, inspired oxygen tension here at the mouth is 160 millimeters of mercury or 21 kilopascals. Water vapor pressure is 47 or 6 kilopascals. Dalton's law, that means that the inspired atmospheric pressure is now down to 713, resulting in a drop of the inspired oxygen tension at the larynx to 150 millimeters of mercury or 19 kilopascals. And gas works its way down through the 23 generations down into the alveoli. Now we know if we take a blood gas that we know what the arterial PCO2 is, and as I've mentioned already, the arterial CO2 equalizes with the alveolar CO2. So what's coming out on the pulmonary venous side of the circulation is equal to what's left behind in the alveoli, and that's around 40 millimeters of mercury or 5.1 kilopascals. And so by doing our little calculation now, we can figure out how the alveolar gas equation works out, and that's 150 minus 50 or 100 millimeters of mercury or 13 kilopascals, and that is the standard alveolar oxygen content. Now let's move on to lung volumes. Our lungs are surrounded by a chest wall. That chest wall involves multiple different structures. At the bottom, it's got a lining, that's the parietal pleura. Then we have our lungs, and our intercostal muscles, and that's coated by more muscles. And on the lower surface, there's the diaphragm. And there is a tendency for that chest wall to spring outwards. It just wants to lift itself outwards. Now, if we remove the chest wall, we have the lungs, and the lungs themselves have a tendency to collapse inwards. So we have two different things going on at the same time, two different counter forces. The chest wall that wants to go out and the lungs that want to just collapse in on themselves. And between the two structures, the chest wall and the lungs, are the parietal pleura attached to the chest wall and the visceral pleura attached to the lungs. And so these two pleura are sucked apart by these counter forces, generating negative pressure within the thoracic cavity. And the point where the tendency for the lungs to spring open and chest wall to spring outwards and the lungs to collapse inwards is the resting point of the lungs, where the lungs will sit if you're not inspiring or actively expiring. So it's the end expiratory lung volume where you have a passive expiration, and that point is known in terms of lung volumes as the functional residual capacity, and it is a really important concept to understand when you're looking at respiratory physiology. And again, to make that point again, it's the point where the lungs are essentially at rest at the end of a passive expiration. And there's roughly 2.5 liters left in the lungs at end expiration. Core to understanding all respiratory physiology is that virtually all gas exchange occurs during expiration, because you only inspire for maybe 8 or 10 seconds per minute. For the rest of the time you're at expiration, and gas is exchanging continuously due to the continuous column of blood going through the alveoli and the continuous exchange of gas from alveoli into the capillaries. So that functional residual capacity is absolutely essential, because that is the reservoir for oxygenation, for gas exchange. We take a breath, that tidal breath or tidal volume may be 350 to 500 mils, and that's what we use to refresh the alveoli, to push carbon dioxide back out of the alveoli into the conducting airways and then out through the mouth, and to replenish a bit of oxygen, although oxygen does move by bulk flow. And so that's about 500 mils, so that the end inspiratory lung volume normally for us is at most about 3 liters. Now, the alveoli do have some extra capacity to stretch up further than that. And if you take a huge big deep breath, you can get up another 1.5 liters into those lungs, and that's known as the inspiratory reserve volume. Also, as I've mentioned, you can actively exhale, you can push gas out of your lungs, and you can keep pushing until basically all the airways start compressing each other and you have gas trapped at the end of an active expiration. So that volume that you can push out at the end of a standard expiration is known as the end expiratory, the expiratory reserve volume. It's probably another liter or so. And then what's trapped at the end of that is the residual volume, whereby no matter how hard you try, you just can't empty the lungs any further. The key thing here is this FRC, the lung volume at end expiration. It's the resting lung volume. And just to say it one more time, most of the time is spent in expiration, so gas exchange occurs in expiration. Having said all that, let's get to the next point. About 30% of your tidal volume, that's that bit above functional residual capacity, never actually gets to the alveoli, because the gas goes in and it goes through all those conducting airways, and then it fills that space but doesn't move any further. So about 30% of the tidal volume just goes into the anatomical dead space. And so the dead space to tidal volume ratio is about 30%. So if the tidal volume is 450 milliliters, then the dead space volume is 150 milliliters, and the ratio is 30%. So you need to get another 300 mils above the dead space volume to actually insufflate the alveoli, to refresh the oxygen, and more importantly, to get rid of the carbon dioxide. That anatomical dead space is fixed. You can't do anything about it. It's there. There are maneuvers to adjust it in very complicated scenarios in the ICU, but for most of the time, you're stuck with it. And if the tidal volume falls, then the dead space to tidal volume ratio increases, the alveolar ventilation falls, and the partial pressure of carbon dioxide rises. Now, here we are looking at a cartoon of an erect lung. And what we have here is the trachea, we have lung parenchyma, we have a series of bronchi, we have the pleura, that's that dark material there, and then we have a series of alveoli. And you'll see the alveoli all look a little bit different. The one up towards the top is kind of brighter colored than the ones towards the bottom. In the erect position, the lungs hang down from the top to the bottom like curtains, and the gravitational effect of the hanging lungs results in the pleura being stretched the most at the part of the lungs that are least dependent. And of course, in the erector, the sitting position, that's the top of the lungs, the anterior apical segments of the lungs. As the weight of lung tissue and gravity compress down on lung tissue progressively as you move right down to the most dependent part of the lungs, the pleural pressure reduces as you go from top to bottom. Now we are at end expiration here, and you can see that we've got two different pressures. In the little green bubbles, we have our pleural pressure, which goes from -10 in the anterior apical segments, all the way down to -2 in the posterior dorsal segments of the lungs because of all that compression. The alveolar pressure at end expiration, as we've previously seen, is about 0. Let's just move this on a little bit. Let's have a look at what happens to the lungs during inspiration. Here we are at functional residual capacity. Note that the lung units in the non-dependent lung regions are slightly more inflated at rest than those in the dependent regions. That's the curtain hanging effect. Because the pleural pressure is more negative in the adjacent regions, that has the effect of sucking open those lung units more than those in the posterior dorsal segments at the bottom of the lungs. We've got all this compression of lung tissue and less negative pleural pressure. Now we're going to inflate those lung units, and you can see here that during inspiration all of the lung units inflate, but the inflation volume is not even throughout. The lung units in the dependent lung zones, those at the bottom, inflate proportionately more than in the non-dependent lung zones. That means they are better ventilated. More carbon dioxide will be removed from these units during the respiratory cycle. So those units at the bottom of the lungs are smaller to start with, but their excursion is relatively greater, so they're better ventilated. The ones in the anterior apical segments, they are already very, very well aerated, but they don't ventilate very well because there's already a lot of gas in them. So let's look at that again. You can see deflation and inflation. Let's add some blood to this picture. So this cartoon depicts blood flow through the lungs at rest. And again, we are in the erect position here. And you can see that blood flow is not evenly distributed. Blood is even more affected by gravity than air, and consequently, blood flow or perfusion also favors the dependent zones of the lungs. So the blood kind of flows downhill, meaning that those dependent lung regions in the posterior dorsal segments in the lower part of the lung here are also better perfused than in the anterior apical segment. So they're better ventilated, as I've previously shown you, and they're also better perfused than the non-dependent regions. So we can now look at the relationship between ventilation and perfusion. And you can see here on the left-hand side at end expiration, you have those lung units in the posterior dorsal segments. They're well perfused. There's not a massive amount of gas in those lung units, but they inflate very well. So when inflation happens here, you can see you get these big excursions, and during inspiration, those lung units in the non-dependent zones may expand so much that the pressure in the alveoli is higher than the pressure in the surrounding capillaries. And as a consequence of this, there is impedance of blood flow during inspiration at the posterior dorsal segments because you're getting this big waft of ventilation. There's a great clearance of carbon dioxide from those regions, but not in the anterior apical segments. Not a huge. There's an increase in the size of those lung units, but it's compressing the alveoli. The capillaries around those points. Now that's not usually a problem because inspiration is relatively short compared with expiration, and so even though you get low ventilation and low perfusion of those lung units during inspiration, it's not usually a real problem for most people. However, if blood perfusion pressure to the lung falls, such as in hypovolemia or vasoplegia, that's pathological vasodilatation. Or if the alveoli in these regions are overdistended throughout the respiratory cycle due to PEEP, for example, there is a significant proportion of lung tissue that will be ventilated but not perfused. And this is known as physiologic dead space. I'm going to show you another little cartoon on this just to elaborate. In this cartoon, we have a situation whereby there is either low blood volume or low perfusion pressure or excessive inflation of lung tissue, such as occurs due to excessive intrinsic or extrinsic PEEP. And the result is that blood is no longer flowing around the alveoli. These lung units become dead space. And the CO2 does not diffuse into the alveoli, and there is a reduced surface area for CO2 removal, and all of this results in the arterial CO2 tension going up. But simultaneously, the end-tidal CO2 tension goes down because their overall ventilation is poor. And this can be really misleading, because if the only way you're measuring carbon dioxide is looking at end-tidal CO2, if you've got a huge problem with dead space ventilation, there is a huge mismatch between the alveolar, the capillary, and the end-tidal CO2. And so when we're looking at the dead space ratio, you need to look at the arterial to end-tidal CO2 ratios. Now let's go back to the ICU. Remember Freida. Freida was intubated on a ventilator and volume assist control, and she was getting 370 mils 15 times a minute, some PEEP, and 28% oxygen. So she wasn't breathing, but she was oxygenating pretty well here. Now Freida is triggering the ventilator, and we've decided, well, we really want to move her on. And remember, her blood gas was good. Her CO2 was 40, PO2 was 100, bicarbonate normal, pH was normal. So we're going to take Freida now, and we are going to put her on a spontaneous breathing mode. I haven't talked about spontaneous breathing modes. That's for the tutorials that are forthcoming on assisted spontaneous breathing. But we're going to put her on one of these modes now. And what we're going to do is we're going to let her breathe away for 15 or 20 minutes, and then we're going to come back and see what her gas is like. Now, it's important to understand that her minute ventilation before we do this is about 5.5 liters. So we come back after 30 minutes and we find that she's breathing away. And guess what? Her minute ventilation is still 5.5 liters, but the components of that are different. The tidal volume has fallen down to 240 mils, and she's breathing a little bit faster at 23 times per minute. So despite the fact that the machine is saying 5.5 liters, it is a little bit different. And that's why when we get her blood gas, it's a little bit surprising, because on her blood gas, her PCO2 has increased from 40 millimeters of mercury, it's 5 kilopascals, up to 60 or 8 kilopascals. And that happened fairly quickly. And the PaO2 has surprisingly dropped from 100 millimeters of mercury down to 70 millimeters of mercury, or 9.2 kilopascals. Well, what's happened here? Well, let's start with the oxygen, because that's the easy bit on this. As we have seen, the PCO2 has risen, and it's gone from 40 up to 60 millimeters of mercury, and the PO2 has dropped from 100 down to 75 millimeters of mercury. The explanation for this is the alveolar gas equation, and because really what this shows is that because the alveoli have more carbon dioxide in them, that CO2 is essentially displacing the oxygen in the alveoli. And so you can't get, because the CO2 is sitting there and it's not moving because of inadequate alveolar ventilation, the problem is that the CO2 isn't clearing out and the oxygen isn't being replenished because of the relative partial pressures. So the alveolar oxygen content is low, but the hypoxemia is being driven principally by the hypercarbia. Why did the PaCO2 rise? The minute ventilation was the same. This cartoon represents the conducting airways. That VD of 150 represents the dead space, an anatomical dead space of 150 mils. The two bubbles represent the alveoli of both lungs, and we are at end expiration. Note that there is a CO2 tension gradient between the pulmonary arterial blood, the alveoli, and the pulmonary venous blood, and indeed with the end tidal CO2. I'm going to do a whole tutorial on end tidal CO2 next after this tutorial, but there's always a little bit of a gradient between the alveolar and the end expiratory CO2. Now we are going to deliver a 450 ml breath. Note that the anatomical dead space is 150 mils, or 33% of this. Although the pulmonary arterial and venous CO2 change little, there is an increase in the alveolar gas of 300 mils, and that's 150 mils roughly spread between the two lungs. So the alveolar CO2 is diluted and the partial pressure is lower. Release of this gas during expiration propels it into the anatomical dead space and then out of the lungs. As inspired and expired tidal volumes are equal, CO2 is effectively cleared from the respiratory apparatus, such that the alveolar ventilation per minute clears 200 or so mils of carbon dioxide and maintains the partial pressure of CO2 in arterial blood at 40 millimeters of mercury. Because Freida's tidal volumes are quite small in this situation in early expiration, where we've given her 240 mils, only 90 mils of gas is delivered beyond the anatomical dead space and into the alveoli. So this is what's happened here with the smaller tidal volumes. This results in lower dilution of carbon dioxide and a reduced partial pressure gradient for gas movement. Consequently, less gas is cleared from the blood, resulting in pulmonary venous hypercarbia. The low tidal volume struggles to escape the dead space, resulting in CO2 being stuck in the major airways. It is then redelivered to the alveoli during the next breath. As a consequence of this, the pulmonary venous and arterial systemic PCO2 rises rapidly. And at some stage, with all of this low tidal volume breathing, the patient starts to become profoundly hypercarbic. And you can see here now that the pulmonary arterial CO2 level has risen up to 52 millimeters of mercury. The pulmonary arterial CO2 level is 48 millimeters of mercury, and the alveolar content has now risen up to 50 millimeters of mercury. So this patient is profoundly hypercarbic. And that's what's happened here, because most of the minute ventilation that's been given to Freida is only ventilating the dead space and a tiny amount of the alveolar surface area. The CO2 has not been adequately cleared, and as a consequence, the patient develops profound systemic hypercarbia. In addition, because of the endless recycling and buildup of carbon dioxide in dead space, the end tidal CO2 initially stops mirroring the arterial CO2 level. And this happens occasionally under anesthesia when the anesthesiologist attempts to allow the patient to breathe spontaneously. A low tidal volume and low end tidal CO2 is observed. However, if assisted ventilation is rapidly applied at this point with greater tidal volumes, the end tidal may actually increase rapidly and scarily to very high levels. So the problem here is relative hypoventilation because of low tidal volumes and a high dead space to tidal volume ratio. Now, if you start off with this picture, remembering that generally tidal volumes improve over time in anesthesia because the CO2 may be less effective at driving respiration under anesthesia, but it certainly has an effect. And what usually happens in these patients is that eventually the gradient between the alveoli and the dead space and the airway equalize so that the end tidal CO2 again reflects the arterial CO2 level. And if that level stays the same, it is likely that alveolar ventilation is sufficient to reach steady state and the patient can continue to breathe spontaneously. albeit with an impressive but likely unharmful respiratory acidosis. So if that end tidal is staying more or less the same, the patient is fine. You don't need to do anything else. If, however, the end tidal CO2 continues to rise, I would strongly recommend putting this patient on some form of inspiratory assistance, such as pressure support ventilation. The bedside clinician correctly determined that the problem was inadequate alveolar ventilation rather than minute ventilation. And so they changed the vent settings to the following. The tidal volume was increased up to 400 mils. The respiratory rate was increased to 30 breaths per minute. That's 12 liters per minute from where we were, with the expectation that they would, when this end tidal CO2 started coming down, they'd turn down the rate. The inspired oxygen tension was increased to 35%, and because the patient was relatively hypoxemic, they increased the PEEP level from 5 to 10. So several maneuvers here: increased tidal volume, increased respiratory rate, increased oxygen, increased PEEP. So what happens with Freida? Well, 30 minutes later, a blood gas is drawn in anticipation of reducing the respiratory rate. However, everyone is surprised to discover that the PCO2 is 60 millimeters of mercury, 8 kilopascals. The PO2 has improved, but only to 85 millimeters of mercury, and the end tidal CO2 is only 20 millimeters of mercury, or 4 kilopascals. Well, what's going on here? In this cartoon, I've again reduced the two lungs to twin bubbles. In this case, I have changed the aspect. In this picture, one bubble is on the top of the other. The higher up represents alveoli in the anterior apical segments of the lungs, while the patient is lying supine. The lower bubble represents alveoli in the posterior dorsal segments of the lungs. Take note that in this position, the anterior alveoli are stretched open by gravity, and that blood flow is lower. So these lung units are neither well ventilated or well perfused, and they have a high ventilation to perfusion ratio. Conversely, the lung units in the posterior dorsal segments are both well ventilated and well perfused, so they have a relatively equal ventilation perfusion ratio. So you're going to have much better gas exchange than those dependent lung units in the posterior dorsal segments of the lungs. Now let's change the vent settings and increase the PEEP from 5 centimeters of water to 10 centimeters of water. Positive end expiratory pressure elevates baseline airway pressure such that the alveoli are relatively better inflated at end expiration. This is used to treat and prevent areas of lung collapse known as atelectasis. Now we've given this patient PEEP, and the problem here is that PEEP is non-discriminate. It applies to all lung units regardless of whether or not they're already filled with gas, as long as those units are relatively compliant. In this situation, both our lung units are affected. The anterior apical segments are completely overdistended and they become dead space. The posterior dorsal segments also inflate, and now they are high VQ segments. So where we had really good ventilation perfusion matching in those areas, now those lung units are a little bit overdistended. Consequently, a lot of the gas going in and out of Freida's lungs, a very high proportion of that gas at the very least, is being wasted. This manifests as hypercarbia, and it's another cause of physiologic dead space. So this is physiologic dead space caused by PEEP. How do I calculate out the dead space to tidal volume ratio? Well, this calculation is relatively easy. All you need to do is take the arterial CO2 level, subtract the end tidal CO2 level, and divide by the arterial CO2 level. So let's work that problem. The arterial CO2 level here is 60 millimeters of mercury. That's the partial pressure of CO2. The end tidal is 20 millimeters of mercury. So doing the mathematics, 60 minus 20 divided by 60 equals 0.66. So what we have here is a 66% dead space ratio. That is a really high ratio. It's twice what it should be, and it's a real problem for clearing carbon dioxide. So there's a major part of the problem there. Now, did the respiratory rate of 30 breaths per minute contribute? And this is an old picture of mine. And what you see here is a patient on a volume control ventilation. This is obviously volume cycle, so you can recognize that shark's fin picture. And if you look carefully at the flow waveform, you'll notice that the expiratory limb of the flow waveform looks all wrong. The very, very beginning of the next breath seems to happen before expiration returns to baseline. And this is known as auto-PEEP. This is gas that's trapped in the alveoli that doesn't have a chance to leave before the next breath happens. And it frequently happens when the respiratory rate is too fast. The gas goes in and it just doesn't have enough time to go out, so the next breath is delivered, shoving that gas back in to the alveoli, essentially giving the patient more PEEP than they should have had. And the development of auto-PEEP is determined by three factors: the respiratory rate, the expiratory time, and the respiratory system expiratory time constant, which is a product of resistance and compliance. As the rate increases, the amount of time available for expiration decreases. Likewise, if the airway resistance increases or the lung compliance decreases, there is expiratory flow limitation and increased likelihood of auto-PEEP. And this really poses a major problem, pressure-targeted mechanical ventilation, as additional PEEP reduces the driving pressure ramp and the tidal volume. And I will get back to that when I'm talking about pressure control. But it is a problem even on volume control, because here it impedes alveolar ventilation by overstretching lung units with high ventilation perfusion ratios. And auto-PEEP is identified here on the flow waveform. When we get to this point E here, that should be right at the baseline, but it's not. It's before the baseline. And again, you can see here the breath taking off. So we can use the flow waveform for identifying auto-PEEP, but you can't quantify it from the flow waveform because it's a pressure. And so to quantify it correctly, you must look at the pressure waveform. And so what you do is you go to the pressure waveform and you apply an expiratory hold maneuver. So you just push a button. It's always there in all the ventilators saying expiratory hold. And so when the breath goes to expiration, a hold is placed, and then you watch the pressure waveform drift upwards from the PEEP level that you're supposed to be at to the auto-PEEP level. And so the combined PEEP and auto-PEEP gives you an idea of what's going on, and it can be quite substantial. We check Freida's auto-PEEP level, and following an inspiratory hold, the total PEEP is 15 centimeters of water, meaning that there is 5 centimeters of water of auto-PEEP and 10 centimeters of water of intrinsic PEEP. And this is resolved by reducing the respiratory rate to 20 breaths per minute and reducing the extrinsic PEEP back to 5 centimeters of water, because this patient never needed that PEEP. She was on 28% oxygen. She just became hypoxemic because she was hypercarbic. 15 minutes later, Freida's PCO2 and PO2 level were within normal limits. In this tutorial, we looked at the topic of ventilation and the generation and clearance of carbon dioxide. We looked at the basic physiology of breathing and alveolar ventilation. And then we looked at the various causes of hypercarbic respiratory failure. Part of that was an introduction to the concept of ventilation perfusion ratios, and we found that high ventilation to perfusion ratio favors difficulty with clearance of carbon dioxide. The extreme version of this is dead space, and of course, if you have a lot of dead space, you can calculate out the dead space to tidal volume ratio, and this is really helpful when you're working in the ICU because there are causes of this relating to mechanical ventilation. 2 of those causes are too much PEEP or the generation of auto-PEEP and an increase in the physiologic dead space. Next time, I will discuss some basics about gases, principally Dalton's and Henry's laws, and we'll then look at end expiratory carbon dioxide. And there are 2 different ways of measuring this, one of which is capnometry, the other is capnography, which is a graphical waveform of the CO2 trace. From there, we will explore abnormal capnographs And it's really useful if you work in the operating room or in the ICU to be able to identify abnormalities in the CO2 trace where it might lead you to make a diagnosis that was otherwise unheralded. We'll see you then. In the next tutorial, we're going to look at one way of measuring carbon dioxide in the body, and that's looking at carbon dioxide in expired gas, the end-tidal carbon dioxide tension. This is very, very useful. It's an essential monitor in anesthesiology and intensive care, and you can use the number for all kinds of things, but the waveforms are even more useful. So please join me then. If you're enjoying these tutorials, don't forget to subscribe and leave me some likes and some comments below on YouTube. And don't forget you can follow these tutorials and others at ccmtutorials.org.